Okay, so good evening, everyone, and welcome to tonight's PEP Talk, recognizing blood clots in uncommon places. This is such an interesting topic, and we're excited to get going. And I think by the 730 people that registered for tonight's PEP Talk, you are also interested in it as well. So tonight we are absolutely thrilled to introduce our clinical guest, which is Dr. Stephan Moll. Fun fact, Dr. Moll was actually the co-founder of the National Blood Clot Alliance, I guess back in 2003, and the original medical and scientific advisory board chair. So we're coming full circle here tonight. By way of introduction, Dr. Moll received his medical degree from Freiburg University in Germany, which included a one-year clinical training in London at the Hammersmith Hospital and Institute of Neurology at Queen's Square. And he also performed a pathology residency at the Institute of Pathology, University of Aachen, Germany. He completed an internship and residency in internal medicine and a hematology oncology fellowship at Duke University. Uh, my goodness, this is quite a background that you have here.
Leslie, make it brief. That's all right.
And it's just amazing. He was recruited back to University of North Carolina in Chapel Hill, where he worked as a coagulationist in the cardiology division of Humboldt University in Berlin, Germany, before being recruited back to UNC, as I said, as a faculty member in the Department of Medicine in the Division of Hematology Oncology. And he has been there since 1999 with the rank of full professor. So there's a few things that we do want to share with you. One is your clinical interest is in coagulation with a particular focus on thrombosis, thrombophilia, and anticoagulation. And your research interests really include clinical trials on new anticoagulants. So we'll have to get you back on to talk about the new factor 11 and 11A anticoagulants that are coming down the pike. But you also have an interest in some very um, interesting areas. So your three main professional goals for the next 5 to 10 years are one, to enhance care provider education on VTE. So thank you for sharing that knowledge. And to continue to build the UNC Athletes and Blood Clot program, which is really interesting. And we have so many folks, as you know, that come to us that are athletes or amateur athletes that are really struggling post blood clot, and also to support trainees in their career development. So thank you for paying it back to the up and coming hematologists. Another really interesting fact is you were well known as the doctor who treated the astronaut in space. Who had a blood clot, speaking of unusual clots and unusual locations. And at the end of tonight's session, we're really hoping to hear that story from you. So thank you, Dr. Moll, for joining us here this evening.
Leslie, thank you for
Um,
having me here.
Delighted. We're so very fortunate. So before we get started, I just want to remind everyone that we are not here to give a specific medical advice. Tonight's session is for educational purposes only. As we often tell you, everyone's clotting situation is unique, and you really do need to speak with your medical provider directly. So please just remember this is for education purposes only. With that, I'm going to turn it over to my PEP partner, Todd Robertson, who's going to lead us through some pre-discussion questions.
I
Todd?
am your poll question guy, and welcome everybody, including all the support group members. So glad you're here. See a lot of you here. Here we go. Going to ask you 5 questions. If you could give your answers, that'd be great. And then we're going to give an exit poll when we're done. Before tonight, how familiar were you with blood clots in locations other than the leg or the lungs? Not at all, a little, moderate, very. Question 2, which of these have you heard of as possible clot locations? Select all that apply. The brain, a CVST, neck, jugular vein, arm and shoulder, abdomen, eye retina, pelvic compression, May Thurner, or none of these is the final box you can check. Our third question, how confident are you that you could recognize symptoms of an unusual location clot? Not confident, slightly confident, moderately confident, very confident. Question 4, do you think unusual location clots are harder to diagnose than classic DVT or PE? Yes, no, not sure. Our final question, how confident are you in your understanding of how these clots are treated? Not confident, slightly confident, moderately confident, or very confident? If you could answer those, we'll go over the results real quick.
I'm excited to see the results.
All right, here we go. Let's go back to question 1 before tonight. How familiar were you with blood clots in locations other than the leg or lungs? 16% said not at all. 43% said a little. 23% said moderate. 18% said very. Which one of these have you heard of as possible clot locations? Select all of that apply. 77% said brain, so a lot of people have heard about CVST. 44% neck jugular vein. 63% arm shoulder. 55% abdomen. Eye retina had 33%. Pelvic compression, 36%. None of these, 9%. Our third question was, how confident are you that you could recognize symptoms of an unusual location clot? Not confident, 45%. Slightly confident, 45%. 8% said moderately confident, and 2% said very confident. Do you think unusual location clots are harder to diagnose than classic DVT or PE? 83% said yes. 1% said no, 16% not sure. Our final question, how confident are you in your understanding of how these clots are treated? 54%, Leslie, said not confident. 25% said slightly confident. 18% moderately confident. Very confident, 2%.
Okay, so 98%. We all have some work to do. I fall in that 98% camp, that's for sure. Okay, so Dr. Moll, this is going to be a very long question, so we'll probably break it into a couple pieces here. But I'm kind of stating the obvious to you, but most public and clinical awareness focuses on leg DVT and pulmonary embolism, while clots in other locations are far less familiar. I'm at a conference today, and the topic is all about pulmonary embolism, pulmonary embolism, pulmonary embolism, and a little bit of DVT. There's not been one discussion about other clots except for those two locations. So talk to us about what unusual location means, and then we would love for you to define and contextualize some of these sites. And I'm going to run through them for you, but we'll probably rerun through them because there's so many of them. CVST, jugular vein. We actually have quite a few folks that have come to us with that. Behind the knee clots, popliteal, May-Thurner, upper extremity clots, speaking of athletes, thoracic outlet syndrome, Paget-Schroeder syndrome, splenic and abdominal clots, such as portal vein thrombosis, mesenteric vein thrombosis, renal vein thrombosis, retinal vein thrombosis, and of course, clots caused by uterine fibroids. We've actually had a fair amount of women comment on that they've experienced that themselves. So put this into context for us. What are unusual clots? And then help us define and contextualize these sites.
Good question, Leslie. Unusual clots are not common, even though a number of the people in the audience have had these clots, and that's why they're here. But if you really look at the general population, these unusual clots are not all that common. So the reason why people talk about DVT of the legs and pulmonary embolism is because they're so much more common. Mm-hmm. And from a health point of view, it makes sense that the general public should be educated about what is common. The general public cannot remember and doesn't have to remember all the symptoms of these different unusual clots, because it's so unlikely that an individual will develop these clots. Yes, there are some individuals who had higher risk for the unusual clots, be it that they have a strong inherited clotting disorder, be it that they have a strong acquired clotting disorder, cancer, antiphospholipid antibodies. So there's somewhat of a higher likelihood that they will develop an unusual clot. But those are still uncommon. It's mostly DVT-PE. So I fully am supportive that everybody in the US should know the symptoms of DVT of the legs and pulmonary embolism. But I think it's not possible that everybody would know the various symptoms of unusual clots. Healthcare professionals even struggle with some of these issues. So the general public, that would be asking too much. And then you ask, what are unusual clots? So really, we talk about DVT of the leg. that's common. Pulmonary embolism, that's common. So any of the other locations are uncommon clots. And we have to distinguish, which many of you know, but not everybody, the plumbing system. That we mostly talk about clots in veins, but clots in arteries occur as well. And that's in a way unusual as well if it happens in a young person who doesn't have diabetes and high blood pressure and smoking and overweight and the arteriosclerosis risk factors. But the ones that you listed are almost all venous clots. So just imagine the veins, or the way the plumbing works is the arteries pump the blood into the periphery, into an organ, into the eye, into the head, and the veins lead the blood back to the heart. So if you have a clot in the vein anywhere, you still pump blood into that part of the body, but it cannot come out. So the typical symptoms of a vein clot, no matter where they are swelling, and that's true for the DVT, pain, because swelling is painful, and then some organ damage, depending on where the swelling happens. If the swelling happens, let's talk maybe head to toe. So if you have a clot in the veins of the brain, that's the cerebral and sinus vein thrombosis, CSVT, or often also called just sinus vein thrombosis. People still pump blood into the brain, but it cannot come out, or it's slow to come out. So there's swelling of the brain that leads to headache. It may lead to vision symptoms, blurred vision, and it may lead to neurological symptoms because part of the brain in that area is damaged. So there's specific symptoms for the CSVT. Then you mentioned the IJ clot, internal jugular vein. So you still pump blood into the brain. It tries to come out, but then there's a blockage. It cannot come down. So you have facial swelling. Again, you may have brain swelling and the headache and the vision symptoms, neurological symptoms. And the clot can, from the IJ, expand into the brain and cause a cerebral and sinus vein thrombosis. If you have a vein clot in the arm veins or the shoulders that you mentioned, thoracic outlet syndrome, you still pump blood into the arm, but it cannot come out. So those are the symptoms very similar to a DVT of the leg: swelling, pain, redness, and warmth of the extremity. Then you go down and you talk about intra-abdominal clots that some people call splanchnic vein thrombosis. And those are clots in the veins of the organs in the abdomen, in the liver, the kidney, the spleen, the mesentery. So you still pump blood into those organs. Well, that gets a little more complex. So let's say in the intestine, superior mesenteric vein thrombosis, you still pump blood into the intestine, but it cannot come out. So the intestine swells. Swelling is painful, so patients will have abdominal pain. And if you have swelling of the intestine, people typically have nausea or vomiting. So those would be the classical symptoms of a mesenteric vein thrombosis. If there's a clot in the kidney, in the veins of the kidney, you pump blood into the kidney, but it cannot come out, so the kidney swells. So people have flank pain where the kidney is. And the outflow of the kidney is impaired, so people may have blood pooling in the kidney and that goes into the urine. So they may have blood in the urine. And then in the liver, if you have outflow obstruction of the liver, and that's called a hepatic vein thrombosis, people still pump blood into the liver swells up, so people have abdominal distension, again, abdominal pain, they have nausea, they have vomiting. The liver may not work right because it's swollen and damaged, so people may turn yellow. And then retinal. Sorry, these are all these individual clots with all different symptoms, but I think the combination, what connects them all on the vein side, is that the organ swells up and there's some damage to the organ, brain, kidney, arm, even the retina. You mentioned the retinal clots. If you have a retinal vein clot, you pump blood into the eye, but it cannot come out, so the retina swells up. The vision is blurred. And people may have some vision loss. It may also be painful. Even though pain, I must say, in the retinal vein in the retina is typically not a major issue. And then Yes, maybe I'll let you pitch in there and see where we take it. We could talk about, you mentioned May-Thurner syndrome. Those are the
So
compression.
let's just finish up with uterine fibroids. How about that? And then we
Yeah,
can go through.
well, yes, we can. So, and actually, I group them, Leslie, into the compression syndromes that cause blood clots. Let's start with the fibroids. So the uterus can have fibroids inside and that doesn't really have impact on the veins outside the uterus, or the fibroids can be on the outside of the uterus. And since the pelvic veins that drain the leg are close to the uterus, if the fibroid is big enough and if it's in the right location, it can compress the pelvic veins on one side or the other or both, and then pelvic vein occlusion or obstruction may lead to back. The blood cannot drain from the leg. So you have leg swelling, leg pain, and the compression may then lead to no blood flow through that area and a blood clot. So fibroids can be associated with, as it can be a risk factor for DVT. Usually they're not. They're either not big enough or they're not in the bad location. And it's often difficult to tell, do they really play a role? Because fibroids are so common and DVTs are so common. And that's the case with many of these clots, that if they're common things, they will happen in one patient, both at the same time, without necessarily being causatively related.
Mm-hmm.
And with fibroids, I often struggle because as a hematologist, I get the ultrasound reports from the gynecology and they just say multiple fibroids present. And you don't really know where they are. So for the hematologist, it's good to look at the CT scan and see, are they close to the venous system or not? Did they really play a role or not? Because that will eventually have treatment consequences regarding how long to treat. If the uterus was taken out or the fibroid was treated, then you wonder, well, the risk factor for the DVT is gone. Can we stop blood thinners? But if the fibroids were just coincidentally found and the DVT is an unprovoked clot, then that patient would be on long-term blood thinners. So it may matter regarding the treatment, the length of treatment.
Mm-hmm. Okay. And there doesn't seem to be a tremendous amount of research on this area, but yet we still have a lot of folks come to us and say that they've had uterine fibroids and that could be the cause of their clot. So it's myself included, although I'm referred to as unprovoked. So there seems to be like in terms of the plumbing, as you say, between some of these clots and classic DVT PE, but in certain instances there are not. Can you just walk us through how CVST usually begins in a person, and is it more common in women than it is in men? And the jugular vein thrombosis, like how does this all come into play in the body?
Yeah, so the cerebral and sinus vein thrombosis, again, relatively unusual. And yes, it may be more common in women. I think some things are so universal true that one should talk about those first.
Okay.
Whenever somebody has a blood clot, a DVT of the legs, pulmonary embolism, or an unusual clot in one of the veins that we just discussed, typically blood clots are multifactorial, that multiple risk factors stack up against a person. It's not just one thing that caused the clot. And we know that from DVT-PE, from the leg DVT, you list the risk factors: A, immobility after surgery, major surgery; B, immobility for the next 3 weeks; C, the body mass index of 33; D, family history; E, maybe somebody tested for clotting disorder, etc. So it's multifactorial. And that's important eventually for the decision how long to treat, because the question is which of the risk factors are constant and which were just transient, the surgery, the immobility, maybe the hormonal therapy, and which one is permanent. Well, the family history, maybe the weight, maybe the factor V Leiden that was discovered, maybe the cancer. So the same approach is true for the unusual clots that we wonder, and you mentioned the cerebral and sinus vein thrombosis. You identify the risk factors. in you see the patient, for example, you ask about, did you have any infection, a mastoiditis, inner ear infection, extensive sinus infection? Those can be inflammatory, and since the veins are closed, people may develop blood clots. Then you wonder in the women, and that's why maybe these sinus vein thrombosis, CSVTs, are more common in women. You ask about hormonal therapy, contraceptives with the estrogen, progestin contraceptives. So that might be your risk factor B. You then eventually will get in obesity leads to inflammation in various parts of the body, not well defined how much of a risk factor it is in unusual clots, but it might be worthwhile to list. Then you take a detailed family history. Is there family history in first-degree relatives, second-degree relatives? And in the unusual clots, if there is no transit risk factor, i.e. no inflammation, infection, or surgery for that matter, so if it's really somewhat unexplained, then a clotting workup, a thrombophilia workup may very well be appropriate. And I classically do that to further find out, why did this individual develop an unusual clot? And if you find a strong thrombophilia, like homozygous 5 Leiden, or like antiphospholipid antibodies, not just the mild thrombophilias like heterozygous 5 Leiden or the heterozygous factor 2 mutation. So if one finds a strong thrombophilia, that may be a reason to treat long-term with anticoagulation. It may influence what we do with the length of treatment. But the first step, whenever we see whatever unusual clot the patient has, once we've diagnosed and defined it, what were the contributing risk factors, A, B, C? The COVID, for example, or an underlying Crohn's disease, inflammatory bowel disease, rheumatoid arthritis, or the cancer.
Okay. And then just walk us through, I know we didn't actually, one of the things that I think we didn't talk was SMV. And I know somebody's already commented on that. So that's one of the sites that we left off. Explain what that is to the audience.
So the SMV is the superior mesenteric vein that drains part of the intestine. So again, if you have a clot there, you pump blood into the intestine, it cannot come out, intestine swells, abdominal pain, nausea, vomiting. And those are often, or not infrequently, diagnosed with delay because the symptoms are unspecific. They're not necessarily immediately dramatic. They have more often a slower onset. So some abdominal pain, something is not right. And then it may be a week or two that patients finally get diagnosed when the clot is progressive and then the intestine becomes damaged. And maybe sometimes people do surgery because the intestine part of it has died, or they just do a laparoscopy or laparotomy to find out what is going in the abdomen because the symptoms are so unspecific. But it's one of those splanchnic or intra-abdominal clots similar to portal vein thrombosis or splenic vein thrombosis, unusual clots in the abdomen.
Okay. And then walk us through, just for everyone's educational purposes, May-Thurner syndrome, what exactly it is. And again, is this something that women tend to get more often than men? And then we also want you to talk about thoracic outlet syndrome because we hear a lot about this with athletes. So can you walk us through what those two conditions are?
Yeah, and if you allow me, Leslie, I'll go from the top to the bottom so that I don't forget.
Go right ahead, go right ahead. If you forget any, we're here,
So thoracic outlet syndrome is where some structures in the neck, be it an extra rib, be it an extra unusual attached muscle or hypertrophy of a bigger muscle than usual, or an extra tendon or an unusual inserted tendon, compresses the subclavian vein, which is the main vein where the drainage of the arms comes into the chest and then goes to the heart. So again, it compresses the outflow, so patients have arm swelling and arm pain and an upper extremity DVT. And this compression is more in everybody, in healthy individuals, when we lift up the arms. So if there's a predisposing compression already, the partial, and then this individual does activities like drywalling by home renovation, or as a baseball pitcher or volleyball player, then there is prolonged compression that leads to a DVT, can lead to a DVT, and then an arm DVT. So that's the thoracic outlet syndrome. However, And the symptoms are the same or similar to DVT in general: pain, swelling, redness, and warmth. However, thoracic outlet syndrome also can compress the nerves in this area, which is completely different, but it's also called TOS, or thoracic outlet syndrome. So it's the nerves that go to the arm. So people have arm pain, but not necessarily swelling, no DVT symptoms. And that's important to differentiate from a venous thoracic outlet syndrome. Or people can also have compression of the artery, which is an arterial TOS, thoracic outlet syndrome. Arteries pump the blood into the arm. So if you have an arterial TOS, there's insufficient supply of oxygen to the arm. People have pain, no swelling. The arm may be, the fingers may be cold and white. Very different story. Also needs intervention, but much more often, much more acute and immediately threatening, because you cannot be without oxygen for too long before you lose the fingers or the hands. That's a thoracic outlet syndrome. They're difficult, somewhat difficult to really diagnose for sure, because, as I said, even though people who don't have the underlying true thoracic outlet syndrome addressed, we all have compression when we lift up the arm. So if you do those studies, the question is that really meaningful, or is that a normal variant? And if you've had a clot in those areas, you may develop scar tissue, as many people after DVT do. And then you wonder, well, is that narrowing due to scar tissue, the old clot, or is it really the overlying tissues causing thoracic outlet syndrome? And while a treatment option for thoracic outlet syndrome is surgery, you don't want to rush into surgery in patients who don't really need it. So the diagnosis of TOS can be very difficult, and it can be very difficult also to decide which patient would really benefit from thoracic outlet surgery. That's not a decision typically that where one can say, oh, all patients with this and this should do. It's a very individualized decision. And it's often a decision between the vascular interventional radiologist, the vascular surgeon, and then the hematologist. Discuss, what do you think about this and what should we be doing?
And I'm just curious because and you do treat so many athletes. We've seen, I think Nelly Korda, who's the number one women's golfer in the world, or was number one golfer in the world, she had thoracic outlet syndrome. She came back from it, but yet the Phillies pitcher and some other folks have not come back yet. And some folks have actually had to leave their professional baseball careers. What is it about the difference in the patient that allows for a comeback to their sport versus others that don't?
Well, Leslie, I don't think I can give an overall answer to that, because these are not common clots. So patients are very individualized. So you really would want to know, what are the various risk factors that the patient had? Was it repetitive movement that makes a TOS more likely? Or is this an unprovoked, out of the blue arm clot that's not really due to the compression? And I highlighted that it can be difficult to tell the changes that you see after DVT. Are they just simple scar tissue, or are they due from the overlying compression of the tissues? And then, as with DVT of the leg, some people recover completely. They have bypassing veins or the collaterals, or they reopen the clot, recanalization. And some people have significant post-thrombotic syndrome, chronic swelling. And that will determine whether an athlete, high-level athlete, can get back to the usual activity level they used to have, or whether they're just not at the level anymore that they should be. Yes, so I think a point I'm making, and I've said that once or twice already, but it's difficult to make any overall statements for these unusual clots. It's so individualized depending on what caused the clot, with the ABC contributing factors.
Okay. But there is some commonality in terms of, on the venous side at least, in some locations there is swelling, there is pain, et cetera. So that should help people that are potentially in a situation needing to get diagnosed, that there is some commonality associated with it. Very quickly before we move on, just for the audience, explain to us why May-Thurner syndrome, what it is and why it's included in unusual, even though it's kind of unusual.
It's not unusual. It's kind of unusual, but it's not. So it's where the left common iliac vein, that's the pelvic vein in the left pelvis, is compressed from one of the overlying big arteries, the artery that goes to the right leg. It's a little complex, but it's lying on top of the vein, and underneath is the spine. So the vein is compressed between the artery and the spine in the back.
Mm-hmm.
The compression leads to decreased flow through that area and turbulent flow, and therefore is a risk factor for DVT in the legs. Now, many people have the May-Thurner physiology, particularly teenagers, probably up to 70% of teenagers.
Oh.
It's more recent data from Bill Marston, a vascular surgeon here at UNC. It's published. And many of these individuals lose the May-Thurner physiology as they get older. So it's not a permanent thing. And even though people typically say you're born with May-Thurner, it's important to keep in mind it's part of the physiological growing up in many people that's clinically irrelevant in many. Why is that important? Well, it's important because if somebody develops a DVT and people find by CT scan, Doppler ultrasound, that there is something May-Thurner syndrome, looks like May-Thurner syndrome, it's wrong to immediately jump onto this and say, oh, the May-Thurner syndrome caused the DVT. Because many people with May-Thurner physiology don't develop DVT. And in many people, it's a coincidental finding of May-Thurner physiology, and they have a clot for some other reason, birth control pill. So it goes back to the multifactorial nature. Yes, it's fine to list the May-Thurner as a possible contributor, but then you have your B, your birth control pill, your C, the family history, etc. And that is important because in practice, one not infrequently sees that the plumbers in the medical profession, which is the vascular surgeons, they see an occluded plumbing system. They think it needs to be opened so that the flow is better. And then they think the risk for clots is gone because now the plumbing is open. But that's a misconception. Yes, the risk for DVT may be less because now there's good flow, but maybe it didn't even play a role. Maybe it was mostly the birth control pill, or maybe it's the family history, or maybe it's a homozygous 5 Leiden. So it would be wrong to then say, well, the May-Thurner is gone, we can take you off blood thinners because there may be other risk factors. Okay. Even more so, if people had a DVT and then, let's say, of the distal thigh above the knee, and then somebody does a study and finds May-Thurner syndrome, vascular surgeons sometimes like to stent things to keep it open.
Yeah.
A stent, however, is prothrombotic. It makes people clot more easily. So you've gained maybe something, better flow, maybe less DVT risk because of that, but you lost something because now you have a stent and you clot more easily, and stents may occlude. So it should not be a reflex that if you find May-Thurner physiology, you need ballooning, or worse, you need a stent placed. So a word of caution about this May-Thurner syndrome.
That's fascinating. I don't think anybody has ever shared or at least explained it that way to us, especially about the stenting. And also the fact that the physiology up until a certain age for women in particular can really change. And
well, not particularly for the women, Leslie. That is true for anybody, but
for anybody.
The May-Thurner may be more relevant in women with pregnancy. When people get pregnant and the baby presses onto the pelvic veins, mm-hmm. If you have a pre-existing partial occlusion due to May-Thurner, now it may get worse because of the baby even pressing completely on it.
Interesting. Okay. I'm going to stop there because I know Todd has some questions also, and I've sucked a lot of oxygen out of the room.
Excellent points on the May-Thurner. I didn't know half that stuff.
Me either.
That's fantastic. And I know you touched a little bit about how hard they are to diagnose, all of these unusual location blood clots. Do these clots have different symptoms or mimic other conditions? And that's what makes it difficult, or partly makes it difficult. And most importantly, how are they typically discovered? Mm. It's difficult enough for a patient to get diagnosed with a DVT or a PE, but now we have introduced a new level of complexity, right?
So I'm not sure they are more difficult to diagnose than DVT-PE. And many of you in the audience, there is not infrequent delay in diagnosing DVT of the leg or pulmonary embolism because other diseases, other disorders have similar symptoms, the muscle sprain, the musculoskeletal, chest pain, the whatever. The same is true for these unusual clots. Take, for example, the intra-abdominal clot, the hepatic vein or portal vein or splenic vein or mesenteric vein, abdominal pain, nausea, vomiting, abdominal distension. It's something that's just not right. This is so unusual that, that's when the provider takes a good history and your suspicion that this could be a blood clot is increased if the patient, for example, had a DVT 3 years ago, or if there's a family history of VTE, or if there's a known clotting disorder, or if the body mass index is extremely so, or if there was, for example, the patient has recurrent pancreatitis, inflammation in the abdomen. Well, that can lead to portal vein and splenic vein thrombosis because they're really close to the pancreas. So the underlying other diseases, rheumatoid arthritis, inflammatory disorders, increased risk for clots in general, Crohn's disease, ulcerative colitis. So you do this assessment. Are there risk factors for blood clots that increase your suspicion that this could be a blood clot? Or is it more likely the location, it's appendicitis? But sometimes people you don't know, and you've done your workup, your liver enzymes, your urinalysis, and then you do a CT of the abdomen or you do a Doppler ultrasound, typically a CT. In the case of sinus vein thrombosis, those are not infrequently misdiagnosed too. Because they may occur in young people, but that's also with DVT-PE, right? The young woman, birth control pill, she has leg symptoms. Well, the provider says, you are young, this cannot be a clot. But the pretest probability is increased because the patient is on birth control pill and maybe there is a first-degree relative with clots. The same is true here so CSVT, headache, that's very common, migraine and what have you. If there's vision symptoms on top of that, that shouldn't really be ignored. But migraine can lead to some vision symptoms for a while as well. But the suspicion again for that this could be a clot is, well, if they had earache, or they have a significant sinus infection, or they had some surgery in that area. So you have some pretest probability, which then makes you think this could be a clot, and then the appropriate testing needs to be done. In this case, it's typically in the jugular vein, it's an ultrasound, Doppler ultrasound. Up here, it's either CT, and it needs to be, and that's another reason why CSVT is not infrequently misdiagnosed. A plain CT scan of the head may not be sufficient. It needs to be CT venogram or an MRI venogram. And that's not often considered. People think, oh, they come in with headache. Could it be a blood clot? CT is negative, is not a blood clot. Not realizing it should have been a CT venogram.
Great point. Great point. Thank you. Leslie?
Okay. So let's talk management and treatment nuances. So does treatment differ by clot location? What are the anticoagulation choices and duration if I don't know, if data is unlimited? How do you balance, and this is, I guess, DVT and PE, but we're applying this to unusual clots and unusual locations. How do you balance bleeding risk versus recurrence risk? And is anticoagulation typically the only option, or are there times when other interventional strategies may or may not be needed? And one of the things that we get asked a lot about with unusual clots in particular is who's making these decisions for them? Is it the hematologist? Is it vascular? Is it IR? Or is it a group of you all together making these decisions?
Well, lots of questions, good questions. In general, and I'm generalizing, realizing every patient is, again, an individual, but in general, if a vein clot is present in a significant, unusual location, anticoagulation, you want to see the patient on anticoagulation to avoid that the clot gets bigger and damage to the organ is done. So whenever there is any of these unusual clots you think anticoagulation probably is needed. It's a little different in the retinal system, and we may want to talk about that, but time will be running short for that. But in general, the thought is I would like this patient to have anticoagulation. If the clot in the unusual location was triggered by a major transient risk factor, the pancreatitis I mentioned, or let's say abdominal surgery, and then the patient develops a portal vein thrombosis, or let's say the mastoiditis, or a severe COVID infection that led to a hospitalization and the patient has some clot, then major transient risk factor is short-term anticoagulation, typically 3 months. That's the same with DVT or PE, right? If there's a major clot after hip replacement, we treat with 3 to 6 months short-term, and we don't treat long-term with anticoagulation. Same thought process with the unusual clots. Where it gets difficult is when it's an unprovoked, out of the blue, unexplained clot. Those are really where, because these clots are so, well, in the case of DVT of the leg and PE, if it's an unprovoked clot, we treat long-term with anticoagulation because there's a high risk for recurrence. That's standard treatment by guidelines with DVT and PE. We have plenty of data that show that the risk of recurrence in those usual clots, DVT and PE, it's a high risk for recurrence if not on anticoagulation, and therefore you use long-term. With the unusual clots that are unprovoked, unexplained, we don't have this wealth of data because these clots are unusual. So we don't know typically what is the risk of recurrence if the patient comes off blood thinners. Can we get away with 3 or 6 months, or do we need to treat long-term with anticoagulation? From my thought process, if a patient has an unexplained cerebral and sinus vein thrombosis, it came out of the blue, they've shown, the patient showed they have a tendency to clot more easily. So I would think probably long-term anticoagulation is appropriate. With this CSVT clot, we do have some degree of idea about recurrences because they're not extremely rare. And it's not an insignificant risk for recurrence if it's an unprovoked clot. So many people treat long-term with anticoagulation, but not everybody because the data are not completely clear. So that's true with an unprovoked splenic vein thrombosis or portal vein thrombosis or renal vein thrombosis. If it's unprovoked, no good reason, my tendency is to think, well, first of all, to recognize and appreciate, I don't know what the risk for recurrence is. There are limited data. And then to say, my tendency is to think long-term anticoagulation if the patient tolerates it well, if the bleeding risk is not too high, and if the patient agrees with it, patient participation is important. So that is how long to treat. In the unprovoked clot then, unexplained, I almost always do a thrombophilia workup. I want any additional information that would indicate this patient has a high risk for recurrence. If they're homozygous for factor V, and if they're double heterozygous, 2 and 5 together, if they have protein C, S antithrombin deficiency, or if they have antiphospholipid syndrome. I saw that somebody in the audience in the chat asked, what about PNH? There's some unusual clotting disorders that predispose particularly to the intra-abdominal clots and sinus vein thrombosis, and that's a JAK2 mutation in the PNH test. So I always do them in those clots as well. So that's the workup. And then the decision is, how do we treat? And it's typically that we use these days the direct oral anticoagulants, the apixaban or rivaroxaban, and in some countries, edoxaban, and then sometimes dabigatran. Warfarin is less commonly used, except there's a special circumstance, a true full-blown antiphospholipid antibody syndrome, where warfarin may be better than the DOACs, the direct oral anticoagulants, even though there's a lot of insecurity and some people overshoot by treating everybody now with warfarin, and that's not appropriate. But typically for these unusual clots, if the decision is let's treat with anticoagulation, the direct oral anticoagulants are used, and mostly it's apixaban these days. Rivaroxaban is a good choice as well. And then can we lower the dose at 3 or 6 months? The same thought process maybe that we do with DVT of the leg and PE, where many data, a number of data suggest at 6 months we can lower the dose. maybe we can do that with the unusual clots, but there are no data on that. In some people, in a number of people, I do that when there's long-term anticoagulation, take down the dose at 6 months, lower risk for bleeding, at least in the DVT, maybe more attractive. That's an individualized decision. If I really don't know what to do with the unprovoked clots and have done a thrombophilia workup and I'm on the fence with the different risk factors, some gone, some permanent, the D-dimer may be helpful. The positive D-dimer may predict a higher risk for recurrence, but the D-dimer has only been tested well in DVT of the leg and in PE. So it's also, point is, often we cannot be dogmatic and say a patient with portal vein thrombosis needs to be treated long-term or, and then you ask what, I said this, in most people we use the direct oral anticoagulants. It gets more difficult in people with kidney failure because the apixaban and rivaroxaban are partially cleared in the kidney, as is the low molecular heparin. So that's really difficult. Then it's the dose adjustment. And in people with hepatic vein thrombosis, liver vein thrombosis, or liver cirrhosis, which leads to portal vein thrombosis, unusual clots, the patients tend to bleed more easily anyway. They have varices, they have hemorrhoids, they have coagulopathies where the liver doesn't make the clotting factors, and the direct oral anticoagulants are partially cleared in the liver. Then it becomes a very individualized decision. Sometimes I use low molecular heparin, maybe dose reduced because of high risk for bleeding. That needs to be, there's no one should use this and this. Warfarin in liver disease, cirrhosis, and portal vein thrombosis, hepatic vein thrombosis. Warfarin is not a good choice because patients already have a coagulopathy because the liver is not working right. So the baseline INR is already elevated.
So one of the things that we did ask about is like who's supposed to be on these teams. I mean, you may think they're not as uncommon as we do, but boy, oh boy, if you don't get Dr. Moll as your hematologist, with some of these things, you're in a very tricky situation. So how should people be navigating these unusual clots? Who should they be having on their team?
So it depends on the healthcare system. So patients may present acutely sick with an acute onset. They come to the ED, and then it depends on where they are. Typically, in the CSVT case, a neurologist is involved, and they get admitted to the neurology service. And then vascular interventional radiology or surgery may be involved because some of the patients right here get thrombectomy. The clot is mechanically removed. Same as with DVT of the leg and the pelvic veins. Some people get clot busters, thrombolytic therapy, not everybody. And that's often a multi-team approach as well with vascular radiology, vascular surgery, and maybe there's an internal medicine person like a hematologist or some internists who take interest in DVT and PE and clots involved. That depends on the healthcare system. The other way people get diagnosed is a delayed diagnosis. So outpatients see them. And that may be the primary care physician or maybe eventually the gastroenterologist if it's a portal vein thrombosis. There, sometimes providers are comfortable treating that. In other situations, they contact the hematologist or whoever their blood clot specialist is if they have one. It depends on the healthcare system.
Okay.
Eventually, however, Leslie, I think a number of these people probably benefit from seeing as an outpatient a hematologist, or sometimes they are pulmonologists or cardiologists who think about clotting workup. Because the question will come up, how long to treat with blood thinners? That's a big question beyond the acute. And probably the more dedicated people, more dedicated people for these unusual clots should be involved in that situation, like a hematologist.
I think that's a great recommendation. I'm just curious, I'm a big believer in patients should know about guidelines, and it made a big difference in terms of how I was eventually treated. But for these unusual clots, is there much out there in terms of guidelines for clinicians and for patients to learn about when it comes to MSV or CVST or, May Thurner or whatever it may be?
Have you heard of the National Blood Clot Alliance? Leslie, you're bringing up a good point. Patient information material is extremely important. And I've been in this field for 25 years, and that's one of the reasons I was involved in to be a founder of the NBCA. Over the years, I've written a number of papers in the peer-reviewed literature that are available for free for patients. The journal Circulation used to have one. The Vascular Medicine Journal has one. So I'm listing them not to show off, but cerebral and sinus vein thrombosis, there have been so many questions. Together with a junior author, I wrote a paper for patients with images about cerebral and sinus vein thrombosis, how to diagnose, what to expect, how to recover, how long to treat. Then similarly, for May-Thurner syndrome, we've written one in one of the journals for the unusual clotting disorders, antiphospholipid antibodies. So there are a number of those out there. And I haven't recently looked at NBCA, but I mean, you have your library of information material. For me, the key is to have a credible organization like NBCA that has good materials and not to just be searching the internet for some information where you see a lot of wrong things. So I think NBCA is on a good path for that.
I think that's a great recommendation, but I do want people to know that there are guidelines and they can access them, especially in this day and age of technology, and to try to educate yourself about it, because I'm just coming back to not everybody has you as their hematologist. And for those of us who have experienced the ugly side of this space, we want to make sure people are appropriately protected. That's
yes.
all.
But Leslie, the guidelines are also difficult. When you don't have sufficient data, it's difficult to give real good guidelines, right? They're typically not very evidence-based.
That's why you want an experienced clinician working with you.
Yeah.
Okay, Todd, I'm going to turn it back to you. And then I know we're a little bit behind schedule tonight. I'm going to ask that everybody stick around though, because we still have a lot to cover.
And I want to ask, Dr. Moll, I want to ask you a little bit about cancer, cancer-associated thrombosis, particularly with splanchnic, portal, and upper extremity clots, occult malignancy versus known cancer, and how does cancer change treatment decisions? I think this is really important because people ask about this all the time. And how about infection and inflammation? When should an unusual clot prompt deeper research for an underlying cause?
So cancer and inflammation, infection typically cause DVT of the legs or pulmonary embolism because they're most common. It's not that they predominantly do unusual clots, but they can cause unusual clots, but that's not that common. With the same applies that we discussed at the beginning. You list your risk factors when you've seen the patient, your A, B, C. In the cancer patient, it matters whether it's a localized tumor or a metastatic tumor. The spread tumors have much more of a risk for clots than a small prostate cancer, for example. The small prostate cancer may be coincidental and may not be causative. Secondly, the patient with colon cancer or any cancer, sometimes they have surgery. So then you have risk factors, cancer and surgery. Well, the surgery is gone, maybe the cancer is gone, they have a low risk for recurrence and short-term anticoagulation. Whereas if it's a cancer that's metastatic, non-curable, long-term anticoagulation. So it's important to, again, list all the risk factors. Some breast cancers get treated with hormonal therapy that are risk factor for clots. Cancer patients often have central venous lines to get the chemotherapy, so that higher risk for IJ clots, arm clots, but then the catheter gets taken out, that risk factor is gone. So you have your A, B, C, D risk factor, which ones are permanent, which are transient. The occult cancer, people have published on that, Mark Carrier. Is it worthwhile in patients with DVT or PE to do a more extensive cancer search in unprovoked, unexplained DVT or PE? And beyond the routine screening, colonoscopy that should be done, age-appropriate, mammogram and what have you, age-appropriate screening, and then a good history. Do you have any symptoms of abdominal pain that's concerning for gastric cancer or colon cancer? A good physical exam. Do you feel any lymph nodes anywhere? And then the basic labs, liver enzymes and the CBC, hemoglobin, are you anemic or not? Beyond that, screening for an occult cancer is not, what is the right word? It's not beneficial. So that doesn't typically get done. I think maybe that's.
You touched on all those points. Yeah, Leslie.
Okay. All right. Before we get to questions, and we have a lot of them. Speaking of clots in unusual places, I believe you treated a U.S. astronaut aboard the International Space Station once upon a time. Can you share that story with us, how that all came to be, and how you were able to treat somebody on the space station and where their clot was, assuming there's no HIPAA violation with the story?
Yeah. So what I'm saying is all not a
And
HIPAA
why you?
violation.
Why did they pick you?
I'll take reference to that. So we published this case in the New England Journal of Medicine. So what I'm telling you, at least the scientific facts, are all public knowledge. So NASA was doing a flow study with ultrasounds of the neck to learn in space, in zero gravity, there's a lot of fluid redistribution to the head. And they wanted to know, what do the vessels do? And that was a research study, which the astronauts, they scan themselves, then this scan is recorded, sent down to Earth, and then 3 or 4 days later, the researchers look at it while they drink their Starbucks and have their feet up on the table. And then suddenly they say, whoa, this astronaut, looks like a DVT. And then it became a clinical issue, not a research issue. Then immediately the flight surgeons were involved, the clinical team. And it's an emergency, obviously, because the DVT jugular vein, it was on the left side, could expand into the brain, causes cerebral and sinus vein thrombosis, could break off PE, could lead to extension into the arm, and then have an arm DVT. NASA contacted me initially. I don't even know, was it email first or probably a phone call, because it was urgent, because one of the Houston sports medicine physician knows about my interest in high-level athletes, unusual populations, and my expertise over the years in DVT-PE. So he was contacted by Houston, by NASA, and he said, this is Ben Levine, called Stephan Moll in Chapel Hill. And then they called me and we talked about this. And it highlights many interesting and relevant things for patients. The first question is always, what we see on the imaging study, is it a real clot? Is it an acute clot, right? Many people with DVT have chronic scar tissue. It's not an acute clot. It's not a clot recurrence. It's post-thrombotic syndrome. So here the question was it a real clot or just a flow abnormality? So then the astronauts scanned themselves. 2 radiologists down in Houston immediately saw the images and then press a little harder, left, right. And then we reviewed those images together and said, this looks like a real clot. And then the risk factor definition, ABC. What are the risk factors up there? Well, zero gravity with fluid redistribution, flow abnormality, maybe. Did this astronaut have thrombophilia? Was tested, none detected. Women on the International Space Station typically take hormones to suppress their menstrual bleeds. So if it's a female, the question will be, have there been hormonal? Then family history, is there family history? So we went through all those ABCDs. That eventually determines mostly how long to treat, but acutely the question was, do you need to treat or not? And given the complications that I mentioned that could happen, the decision was made, yes, to treat, because the patient was at low risk for bleeding. Astronauts, at least the NASA astronauts, are typically on the younger side, healthier side. Risk for bleeding up in space is relatively low because they just float around and they don't bang themselves at high speed and they don't fall. So then, fortunately, injectable enoxaparin, that's also known as Lovenox, was on board. So the astronaut was able to use the Lovenox until the supply ship was able to send apixaban up into space, much easier to take. And then the astronaut was treated with apixaban. Repeat imaging studies showed that the clot developed as it kind of would on Earth, that it gets more organized, it starts to shrink. So then shortly before the astronaut came back onto Earth, I think 3 or 4 days before, the apixamer stopped so that with a landing, which is pretty rough, they wouldn't bleed. And then on Earth, the scanning was done again. There was no clot on Earth, and therefore no further anticoagulation was given.
How fascinating.
Yes, indeed.
And very appropriate for tonight's conversation.
Well, Leslie, then one has to add what was really then fascinating beyond the science behind it. The astronaut who is eventually a normal patient, right? So the astronaut wanted to talk to me as directly to your physician, not through NASA and flight surgeons and all, but just one-to-one. So we made an arrangement that the astronaut would call on a Sunday morning. And at that time, we still had a stationary phone. And I think I must not have told my wife about this for HIPAA reasons, because the astronaut called and my wife picked up the phone, the station, and it said there on the call identifier, International Space Station. And then she said she thought it was a spam call. She said, Stephan, there's an out of space call for you, not realizing that it was really an out of space call. But that was a funny story. But then it turned out this is just a patient out there with concerns like everybody has, right?
Everybody else, yeah.
But you said the psychological toll can be big. And there you are in space and you have a clot and you wonder, what does it really mean? And you want to hear not maybe the NASA opinion, but just what should I be concerned about it? That was actually a very interesting experience that in spite of this person being in space, it just turned out to be as any patient in clinic with the same conversation and relationship that we have in clinics.
Well, it's an amazing story, an absolutely amazing story, and it was perfect for tonight's conversation. We're going to jump to Q&A. I know we're a little bit over time. Stephan, if you would be kind enough to stay with us for a little bit longer. So
absolutely.
Questions, we would greatly appreciate that. And Todd, I'm going to punch it back to you.
Yeah, a couple of questions came in that were submitted, but I get this all the time. So I want to ask you, I mean, you are quite the expert. For those who are on long-term anticoagulation, is there any danger to the vital organs when you're on long-term?
In general, no. I'm going back to warfarin, though. That's not widely used anymore. Warfarin was used for decades. And eventually, towards the end of warfarin, we've learned that in some individuals, it leads to calcification of the blood vessels more commonly than in other people not on warfarin. So there's it was not huge enough that really became into the public knowledge and into the discussions with the patient. The direct oral anticoagulants, apixaban, rivaroxaban, dabigatran, and edoxaban, they've been around now for 12, 15 years, and then they were in development for 5 years. There is no long-term side effect that has come up as a red flag with the FDA and such. So my comment to the patient is bleeding risk is the risk. Beyond that, there's no toxicity that we know of over 15 years or so to kidney or liver or any other organ.
Yeah, and everybody should be getting blood work every 6 months, annually, whatever. And if there was a problem, something would probably show up in the blood panel, don't you think?
So first of all, before Todd, if I may say that, no, not everybody should get blood work every 6 months. I caution, and I think I've said that throughout, not every patient is like the other patient. It's always an individual decision. We have many young people, or even healthy patients of more advanced age, where you don't need every 6 months blood work. It really depends. I classically get a CBC and a creatinine once per year, but even that in some young people may be overkill. I mean, you follow the patients. You never say you're on blood thinners forever and I won't see you again. You have an annual reevaluation or maybe more often. And then you take a history. How do they tolerate it? And then you get blood work. But I mean, the calcification in the warfarin case is not very common. That was just picked up through some research studies where they saw the heart valves are more commonly calcified. But that wouldn't have been picked up with routine studies.
Very good. Yeah.
One just needs to be alert as a provider, right, to symptoms and then clinical findings. And yes, look at the labs too.
Yeah, and like you said, every patient specific, we all have different issues for different reasons. We need to keep an eye on things, and that's something we've got to do. So good point. Thank you. Leslie?
Okay. This is kind of a complicated one. My family has had 5 blood clot cases. One was DVT only, survived. 2 were DVT plus PE, deceased. One was an intestinal blood clot, deceased. And one was a cerebral venous sinus thrombosis, CVST, survived. I'd like to bring this unusual pattern to Dr. Moll. Any thoughts? Is this related, do you think, to some type of genetic mutation and thrombophilia, et cetera?
That's a striking case, but not that unusual either. It allows me to highlight the point I made earlier. Really, one needs to look at each of these individual patients. What were their risk factor for the clot? A, B, C, D. Maybe one person had a DVT after hip replacement. Well, there may not be a thrombophilia. Maybe the other person had recurrent pancreatitis because of hyperlipidemia or alcohol use or something. Well, then a portal vein or mesenteric vein thrombosis would not be that unusual. Maybe the other one was somebody on birth control pills, or maybe had cancer and clots, or maybe was 87 years old and had a clot. So really, details are needed. Even in this case of a family history, one cannot immediately say, oh, this is highly suspicious for a thrombophilia or this or that. I would take each individual with the risk factors and make an assessment. But it sounds striking at first, and maybe there's an underlying thrombophilia, but it doesn't suggest one particular thrombophilia. If several of these clots in the family members are unexplained, then you certainly wonder about a strong thrombophilia, protein C, protein S, antithrombin deficiency, or maybe one of those 3, if I were to take a guess, but could also be homozygous 5-Leiden, double heterozygous. Difficult to tell. The 7 strong thrombophilias that I really think about as acquired are homozygous 5-Leiden, rare homozygous prothrombin factor 2 mutation, the 5-Leiden plus prothrombin mutation, protein CS antithrombin, those are the 6. And then as an acquired disorder, the antiphospholipid syndrome, full-blown. And then the less common PNH, paroxysmal nocturnal hemoglobinuria, and then an acquired one. Well, as we haven't even talked about cancer, but as a thrombophilia for testing the JAK2 mutation in unusual clots like cerebral and sinus vein and portal vein, splanchnic vein thrombosis.
Okay. Todd, I'm going to jump into another one if you don't mind, and then we'll just kind of do a couple as we go here. I started to share this with you a little bit before the session. Somebody wrote in and wanted to know what was blood clot risk with testosterone. If you're taking testosterone, does it increase your risk of getting a blood clot? And or can it cause an unusual clot, or is it just causes clots potentially?
The association of testosterone with blood clots is not strong, and it's not absolutely well defined. I was involved in a meta-analysis, first author is Damon Houghton from the Mayo Clinic, published a few years ago. So we looked at the data, and I've tried to keep up because this question comes up in clinic every so often. Testosterone may be a mild risk factor if newly taken, so in the first year. But if somebody has already taken testosterone for a year and didn't develop a clot, and then eventually after 2 or 3 years develops a clot, likely the testosterone didn't play much of a role. And then it may not just be the testosterone, but testosterone leads to an increase in red cells called erythrocytosis. The hemoglobin goes up. Those may be the patients who are at risk for blood clots on testosterone. So it's not really the testosterone per se, but the consequence of the higher hemoglobin. And then it may also be that it's a patient who have the supratherapeutic levels, way high levels that clot more easily. So if somebody's on testosterone and the hemoglobin is fine and the blood level of testosterone is in the expected range, that likely does not play a role in causing blood clots.
Okay.
And the other group, let's say that comes up, women, sometimes perimenopausal, ask for low dose testosterone. That is such a low dose, likely does not play a role
It's not
in
cause a problem.
clotting risk.
Okay, thank you. Todd?
Somebody was asking, does a fatty liver, does that factor into liver thrombosis and liver issues, having a fatty liver?
Liver issues, definitely. Fatty liver can, in some people, progress to liver damage and liver cirrhosis. Clotting risk, fatty liver, no. Not that I'm aware of. So I do not list it as a risk factor for VTE.
Okay, thank you. Leslie?
Okay,
Todd, one point that I would like to raise, if you allow me, and it may cover some of the questions being asked. We've talked about the multifactorial nature of clots, the ABC, the importance to identify our risk factors. The same is true for bleeding risk, because when we use anticoagulants, we weigh against the clotting risk, the bleeding risk, and that's typically multifactorial as well. The patient may have had a bleed from the lung cancer or the colon cancer. The patient may have hemorrhoids or esophageal varices from the portal vein thrombosis. The patient may have low platelets because of the portal vein thrombosis and big spleen. The liver cirrhosis has a coagulopathy. Patient may be on aspirin for coronary artery disease. So it's what are the risk factors A, B, C for bleeding? That's the second part of the decision, how long to treat, unusual clots as well as others. And then the third part is patient preference. After the discussion, what is the patient's acceptance of the risk for recurrence or the acceptance of a risk for bleeding? And then the financial issues come in of the drug. But that patient preference needs to be considered as well. And you know that.
Absolutely.
Okay. Is it possible to get a groin blood clot?
Well, how do you define the groin? The groin is the area where the leg meets the pelvis. So groin clots is not it's unclear what that really means. It could be a vein in the groin, right? That would be the common femoral vein. And yes, people can have a common femoral vein clot, but it could also be a clot in the common femoral artery. Or sometimes people bleed and then they have a subcutaneous hematoma, or they have a bulge, a palpable mass. And sometimes people call that a clot, even though it's a bleed that has become firm. So with a groin clot, the question really is, what is this individual referring to?
Okay. I have another question. This is actually coming in from a clinician. Are there unusual clots that are continue to be discovered? Have you seen anything new?
Yeah, well, 2 weeks ago, one of our junior physicians saw a clot in one of what was it, the epididymis, the little thing next to the testicle. The patient had a clot there. I had never seen that in 25 years. I have twice seen a clot, a superficial clot in the breast. It has a name and I forgot what it is called. It's a really unusual clot. Is it Monroe's disease? Something. Not really discovered, but they're just so uncommon that people just don't see them. And
Okay.
I mean, we have limited body parts, right? So
Yeah, no, I appreciate the question from the clinician because at least they're thinking about things when patients come in that maybe most folks aren't. Todd, I'd like to suggest maybe you take the last question. It's we're pushing.
let's say allow me to quickly answer, though.
Sure.
While maybe no new clots locations are discovered, what we do learn is new clotting disorders, and that came about with COVID, right? With the adenoviral vaccine that we don't use in the US, but the Europeans and in India was used. That particularly caused in some people cerebral and sinus vein thrombosis. That was a completely new type of mechanism how people clotted. It's a heparin-induced thrombocytopenia kind of,
Yeah.
they called it VIT. And then 2 years ago, and I was involved in those two cases, and we also published them in the New England Journal of Medicine. Those were individuals who had an adenoviral infection, and they developed this vit-like picture with clots, but it was due to an adenoviral infection. That was not known. So there's some mechanisms that are being discovered, which is not surprising because so often we don't know why people clot. Why did they clot on Tuesday and not on Wednesday? Why in 2022 and not 2023?
Were either one of those newer disorders, what about anticoagulation? Were they able to handle that, or were they resistant to current anticoagulants?
Many of the people with VIT died, and one of the two with the adenoviral infection that I mentioned that we published in the New England Journal also died, a child. But the fact that we then subsequently by research learned what makes them clot, now we know how to treat them better, and the survival is much better. We give immunoglobulin, IVIG, similar to what we do in heparin-induced thrombocytopenia.
Sure. So that was kind of an add-on question. So here's my final question. I promised I'd ask this for somebody. My husband has a renal infarct. I wanted to know if this is related to him having a horseshoe kidney. Does that have anything to do with it?
This is a real good question. Well, I mean, all questions are good, but we haven't addressed this. The renal infarct, what we've discussed, could either be due to a vein infarct, renal vein, where you pump blood into the kidney, it cannot come out, the kidney swells up and it damages the kidney. Or it could be an arterial event where there's a clot in the artery, so you have no blood flow to the kidney. So the first question that we ask when we see a patient with an unusual clot is this a clot in the artery or in the vein? Because that determines how we work up the patient. In the arterial clot issue, we look for atrial fibrillation, some left heart issues, arteriosclerosis, diabetes. In the vein clot, those things don't play a role. So it matters whether it's artery or vein. So in this patient, what I would want to see is look at the image and see what is this horseshoe kidney. In general, these are unusual things. What I would do these days, I've not thought about this with a horseshoe kidney. I would go to the AI system that many people now use, Open Evidence, that as healthcare providers, we have access to that. It's out of Harvard. It searches the literature and then puts together a text with references. One has to take it with critical mind still because it's just an AI tool. But with these unusual questions and searches for healthcare providers, I think that's an extremely good tool. So I would put into that horseshoe kidney. Well, first of all, I want to know is a renal artery or vein and the horseshoe kidney and infarct. And I could well imagine if it's a horseshoe kidney, which is an abnormal shape, that the blood vessel support is not usual. There could be a kinked vessel. So I wouldn't be surprised if there is some association, but I would want some details.
Great. I'm glad I asked you that. That's great info. Leslie?
So I just chat GPT'd all your work in unusual clot locations, and I think we're going to have a second round of this because we've only started to scratch the surface here. So unfortunately, we're going to conclude. I could stay here all night long, but I don't want to do that to you guys. We're going to end with some post questions. I have more questions now, I think, than I had even beforehand. So Todd, lead us with the post questions.
Well, and I keep a notebook of notes for every pep talk we do, and this has been the most that I've written down.
It's amazing.
This is just absolutely outstanding. Yeah, we're going to have, here's some exit questions for you folks. If you could do this before you pop off for the night. After tonight's talk, how has your understanding of an unusual location clots changed? No change, slight improvement, significant improvement. I know that would be my choice. Which of these do you now recognize as possible clot locations? Select all that apply. The brain, CVST, jugular vein, arm, shoulder, abdomen, eye, retina, and pelvic compression. That May Thurner bit was also very educating. How well do you now understand why these clots are often missed or misdiagnosed? Not at all, somewhat, well, very well. Fourth question, after tonight, how likely are you to think about underlying causes like cancer, clotting disorders with unusual clots? Not likely, somewhat likely, very likely. Question number 5, how confident are you now in advocating for further evaluation if symptoms do not make sense? Not confident, slightly confident, moderately confident, or very confident. Final question, after this pep talk, what are you more likely to do? Select all that apply. Pay attention to unusual symptoms, ask more questions of healthcare providers, share this info with others, seek more education, or no change. So when those answers pop up, we'll list those off. And yeah, I could do these 90-minute specials all the time,
Oh my God, this was
especially with Dr.
amazing.
Moll. We need
I
like 2 or
Thank you,
know.
3
guys.
hours. These are going to pop up in just a second.
Yeah, I didn't see the questions either when you read them, but I didn't see them come up on
Yeah,
the
and I
screen.
read them off my screen, so they did pop up for me. So here are the answers. After tonight's talk, how has your understanding of unusual location clots changed? 23% slight improvement, 77% significant improvement. Number 2, which of these do you now recognize as possible clot locations? 87% said brain, jugular was at 87%, 93% arm shoulder,
Wow.
91% abdomen, 84% eye retina, and 86% pelvic compression. How well do you now understand why these clots are often missed or misdiagnosed? Not at all was 0%. 34% was somewhat well, 48%, 18% said very well. After tonight, how likely are you to think about underlying causes like cancer and clotting disorders with unusual clots? Somewhat likely 24%, very likely 76%. Question number 5, how confident are you now in advocating for further evaluation if symptoms do not make sense? Slightly confident was at 15%, 30% said moderately confident, very confident 55%. And the final question before we turn you loose, here are the results. After this pep talk, what are you more likely to do? Select all that apply. Pay attention to unusual symptoms, 91%. Ask for more questions of healthcare providers, 94%. Share this info with others, always important, 73%. 82% said seek more education, and only 1% no change. So those were great answers. I think
It's
that was a very
fantastic.
productive poll. Yes.
Dr.
All
Moll,
right.
thank you. Thank you for staying so late with us tonight. And
Absolutely.
Yes.
I think we have you on video saying that you'll come back for a round 2, so you can't get out of it.
Happy to do it, Leslie.
Thank you so much.
Awesome.
Good night, everybody. Thanks.
Thanks. Bye-bye.
Good night.